Thank you for inviting me to talk. So I'm just going to share my screen. Great, so thanks very much for inviting me to talk today. I hope everybody can hear me okay. My name is Suzanne Joels. I work clinically in Camden Memory Service. I'm also clinical director for our Ageing Service and Perinatal Services at Camden Islington Trust. So I'm going to talk to you a little bit about what it's like to participate in the audit and what the benefits are. So I just wanted to fill you in a little bit about our memory service. I've already noticed the spelling mistakes, so apologies for that. But Camden Memory Service, we were set up in 2009, and we are a medical-led diagnostic service. And that means that we have a large number of different doctors inputting, but very limited time. So although we've got 5 consultants, 3 of them only have 1 session a week. We have, pre-COVID, we had 800 referrals a year, and around the time that the audit was happening, we were undergoing service change. So we managed to get funding to move from just a assessment, diagnosis and follow-up of medication service to a service whereby we now follow up everybody with a diagnosis of dementia in Camden from the point of diagnosis until entry into 24-hour care or the end of life. So it was important for us to know a little bit more about what we were doing well and how we were, how our service was faring compared to our local services. And also, as we were changing service and having a lot of service change, the benchmarking was incredibly helpful to us so that we could take ideas and think about how to develop service. Around the development of the audit as well, the other thing that was happening was, of course, our targets, indicators were changing, and we were moving towards, we knew we had this target of a 6-week waiting time. And I think we found it as common with a number of other services. We found it quite difficult to get our performance team and informatics team to pull this data in a meaningful way off our electronic patient record. So one of the things that we were hoping to achieve was to check the validity of our data collection and get a really good idea of exactly what was happening for somebody who'd been referred to our service, who was going through that diagnostic process. And finally, I think the other thing that we hoped to achieve was looking at the overall quality of the service that we were providing, not just looking at timeframes, but actually get a real sense of, is there anything that we could be doing better? And that is difficult when you don't have any significant data. So we were very quick to get involved in the pilot project. And what the pilot project taught us was actually this was a very doable audit. Just trying to pull the information out, we realised that initially it would take about 15 minutes per patient. We have all of our notes are on electronic patient records. Once you've done 1 or 2 audits of patients' notes, it's very quick to be able to know where you need to go to find the information. So that time per patient definitely went down the more patients that you did. As I said, we have a number of different doctors who are involved, and one of the things that I have found in my time with audit is that if you are invested in a whole audit process, then actually any changes that you want to make are more likely to happen. And because we managed to get all of our doctors to take on a small number of patients to complete the audit, it meant that they were really interested in what was happening. It also meant it was a really good way of being able to supervise what was happening with junior doctors. We actually picked up things that we were all doing that we may not have, been entering all of our data correctly. So there was a huge amount of learning just on an individual practice. And it was also very easy to get our doctors, particularly our consultants, to engage in the audit, because by participating, by giving them some 10 patients' notes to look at, they'd fulfilled their requirement for appraisal in terms of audit, and it was a very easy way for them to do that. as I said, it was invaluable in terms of service improvement and development. So one of the projects that we ran was a QI project. We were looking at the time it was taking for people to get an assessment and to receive a diagnosis. So, for example, I know Laura spoke a little bit and showed a picture of somebody's QI project. We'd done something quite similar ourselves. And we'd looked at how we could make small changes along using QI methodology, and some of the change processes that we made involved looking at how we triaged referrals, how we booked in junior doctors' appointments, and that made small changes we found made an enormous difference to the time frames. The benchmarking was also really useful. It gave us ideas in terms of what other services seem to be doing really well. And certainly when doing the audit in London and also having the network in London meant that it was very easy to speak to colleagues, to understand what they were doing, how they were delivering their services, and to embed that in our service change as well. And overall, because there was a huge amount of data and it was a huge amount of data to analyse, and we didn't have to do any of the analysis, we just filled out the audit sheets, which, as you can see from Laura's presentation, is Excel spreadsheets. We just sent them off, and then we got these beautiful reports returned to us with a huge amount of information. So we felt we gained an enormous return for the investment, and being able to discuss it afterwards at the national meetings was really helpful. So I just wanted to pick up a couple of things just to give you an idea of the sort of things that we focused on. So huge amount of data was generated. One of the things that really struck me, and these were results from the 2016 audit, was, and as you can see, I've highlighted we were Service 7 in the 2016 audit. One of the things that I was quite shocked by when our results came back was our rate of diagnosis of mild cognitive impairment compared to a diagnosis of dementia. So we had expected there to be relatively high numbers of people with mild cognitive impairment, and that's partly because of the catchment area that we serve. So we see a lot of patients who live in Hampstead and Belsize Park, which are both very affluent, very highly educated populations who are often quite early in terms of seeking health information. So we knew that we were seeing quite a number of people who may present quite early or may present with mild memory problems. But I wasn't expecting the numbers of the percentage of people with mild cognitive impairment to be almost half the number of people who are actually given a diagnosis. And to me, that didn't feel right. So we did quite a lot of work in terms of talking about what mild cognitive impairment meant. You know, is mild cognitive impairment, are we using it because we're not entirely sure about whether we should be giving people a diagnosis now, and actually let's wait and see what happens, which we didn't feel was particularly good practice. Or are we really making a diagnosis in people who fulfill all the characteristics and the diagnostic criteria of mild cognitive impairment? So that was one thing that we focused on. As I said, you know, because of the demographics of our area, we weren't so surprised we had quite a number of people who didn't have any diagnosis of dementia. The other thing we looked at was our diagnostic waiting time, and that was because we were quite interested in doing this QI project, because we knew that some people seemed to be getting slightly lost in the system, and obviously because we knew that the 6-week access standard was coming up. And although we weren't doing too badly in comparison to the rest of the services, we did feel that a waiting time of 12 weeks was not really acceptable to get a diagnosis, you know, 3 months after your initial referral. We thought we could do that better. So that was another QI project that we looked at, and we looked at, you know, what were the delays in that. And this was a result in the 2019 audit. So we still have a number of people who don't get a diagnosis at all, but actually the percentage of people who were receiving a diagnosis of mild cognitive impairment compared to the people who receive a dementia diagnosis now looks as if it's actually much more appropriate. I think The national audit that was done last year showed an average of about 18%, and I think we were fairly close to that. And again, our average wait from referral to diagnosis, as I said, we weren't doing badly before in terms of London, but I think you can see that we've made a significant improvement. So we've reduced the time taken from 12 weeks to under 5 weeks. So, and that's an outcome that we were particularly pleased with. So I think I've chosen these two indicators because I think the average wait referral to diagnosis was something that I think many of us are looking at and many of us are developing QI projects around. But the project around looking at making sure that we had diagnostic reliability, I think is not something that we would have picked up had we not participated in the audit. So I think, personally, I think there's a huge amount of learning that can be taken from participating in the audit. In terms of the practicalities in participating in the audit, it's really not onerous. It's really not difficult. It's quite easy to organise it. Well, we found it quite easy to organise it, that we actually had more than one practitioner doing that. And as I said, you know, having it analysed by somebody else, getting all the benchmarking data just makes everything so much more painless. So, and I'm happy to take questions.